Good morning.
Good morning.
You heard that I'm a pastor, so if you don't talk back to me, I'll speak more. So good morning again. I was laughing as I got up because Karen and I do these workshops together all the time. So we affectionately call ourselves CARESE, as the collective brain. So we just are glad that you're with us this morning and hope that you will participate in this interactive dialogue session today. So if you would, just put your thinking caps on. We're going to take you on a ride, if that's all right. Of course, I'm going to push the wrong button initially. And there you go. So the reason that Karen and I do these workshops outside of our respect for one another and the work that we do is because of these wonderful people that are inside of this frame. I have my grandson and granddaughter who are kind of right here at the bottom. Jesse, who is 5 now, Brianna, who is 10, and Lisiana, and then Karen's 2 wonderful children, Arthur and Oliver. And we want to make sure that they live in a world that doesn't have to deal with the issues of racism and inequity when they grow up. They should not still be having the same conversation that we're going to have today. So we're hopeful that will start us on a journey to begin discussing how to alleviate some of the health disparities and health inequities, and talk a little bit more about health literacy. So our health is often determined more by our zip code than by access to health care and lifestyle choices. We often tend to blame the victims as opposed to trying to understand the social conditions that may exist within their communities. So today, I'm going to stop pressing the wrong button. Excuse me. So our goal today is to begin a dialogue that enhances our conversation around public health's role in addressing health inequity and social justice. We want to provide a framework for addressing the social determinants of health of individuals, communities, and jurisdictions as a whole, and to transform public health practice from its regulatory and categorical functions to one that addresses the root causes of health inequity, racism, class oppression, or gender discrimination and exploitation. So this photograph, we want to talk and make sure we dialogue within the group. So we're not going to do all the talking up front and then have you just sit there for the next hour, but we want to engage you in a conversation. So when you look at this picture, what do you see? We're just going to ask you to kind of speak back to us in this session. What do you see? What do you notice about this picture? The gaps in the rungs in the ladder. Yep. What else? The person on the right is not climbing as fast as the person on the left. I'm repeating this for the sake of the recording, so it's not that I didn't hear you. Okay, what else? They're different skin colors, yes. What else?
The person on the left is looking down on the person on the right.
The person on the left is looking down on the person on the right. And there are no right or wrong answers to this section. We just really want to hear what you see.
The weather is partly cloudy.
The weather is partly cloudy, unlike today. Right. Awesome. Oh, yeah.
It's easier for the person on the left to reach up.
It's,
the person on the right.
it's easier for the person to reach up on the left than on the right. And why do you think that is?
It's because they can grab on easier to the next rung.
Okay. And it's because they're closer together. Okay. And in the back in the corner?
I was going to go along with that, but it looks like the person on the right is just kind of gripping on. The other one's reaching ahead.
Person on the right's gripping on? Yep. Yes.
The person on the right doesn't have as many choices for going up, because you don't necessarily, both people might be able to climb the right ladder at the same pace, but the one on the left can go up each ladder or skip. There's different choices.
Okay. Different choices. Thank you. Yeah, in the back with the white.
If you were to just look at the ladders, the sides of the ladders, you would think that, they're both somewhat equal or pointing in the same direction, but the experience for each individual would be extremely different because of the number of rungs in the ladder and the amount of effort that would be required to climb each rung.
The amount of effort. That's great. Yep, Takia.
The one on the left can step ahead, and it looks like the one at the bottom can only see one step and don't know what's next.
Okay. Great. We've also had people talk about how the green person sort of is reaching off the screen because it just appears that their options are just limitless. They're not bound by anything, not even the parameters of the frame. Other people have noticed that that person is also above the clouds. Yes, Anna.
The face of the person with the orangey color is kind of like shows expressions of, being afraid or being frightened, which is a reflection of the conditions in which that person may be experiencing.
Okay, person on the right might be fearful. Yeah. The interesting thing is that we don't see what's beneath them. So we don't know where they're starting out either. But we do realize that one person is much further ahead. Great, thank you for that. This comes from the cover of a book from the National Association of City and County Health Officials. I always get that acronym wrong, but today I got it right. Thank you. So we use this in our groups to just talk about how our vantage points might be different, and just based on where we start out or where we are in life, our access to things may differ. So we need to be aware of that as we are working with people. Gotta go back. As we are working with people. There we are. How many people have seen this iceberg before? What's the great unique thing about an iceberg? Yes?
Well, there's so much more below that you don't see. All you see is what's above.
Exactly, exactly. There's so much more below going on that we don't see. There's only 10% of the iceberg is exposed, so the other 90% is under the surface. It's sort of like when you look at someone, you may make assumptions about them based on what you see or what you perceive, but you have no idea what's going on beneath the surface. One of the things that I like to say to people is when you look at me, you might make an assumption about my race or ethnicity based on my appearance. So if you looked at me, you would think that I was African American. Thank you. Don't be afraid. I know who I am and what I look like. I may appear to be African American, pero si yo estoy hablando como eso, then what would you think about me? Dominican, exactly. What'd you say? Espanol, see? So you might not know. So there are things that go on underneath the surface that may not be as obvious as the externals. So the same thing happens when we talk about infant mortality. Infant mortality we see as the 10% that's actually going on that we are aware of, that we see, that we notice that there are these disparities that take place. But the underlying causes or the root causes of infant mortality lie in the 90% of what's taking place behind the scenes. So in all of our studies and all the work that we do around reducing infant mortalities, we're clear that racism has a lot to do with it, because the effects of that high level of continuous, uninterrupted stress does something to the physical body of a woman when she's carrying a child. There's a hormone that's released, a stress hormone that's released when a woman is just dealing with conditions. Now, we have normal stressors that exist, and some of them are listed here. Some people that may not be people of color or may not be dealing with racism may have effects in their neighborhood. They might live in unsafe neighborhoods. But then there are fatherless households, there's premature birth, there's unemployment, there's feelings of hopelessness, other levels of stress, substance abuse, family support. But then when you add racism to it, it takes the level of stress up a little bit higher. So when you have these chronic conditions that don't let up, there's a video that we use in some of our other training, and a woman talks about the stress of racism as like gunning an engine, I can't even talk this morning, gunning an engine and never letting up. Could you imagine what would happen if you had your engine revving high consistently and you kept driving? After a period of time, your car would malfunction. It would stop functioning properly, and then you'd have problems with that car. So it is with the issues of racism and these other social ills that then contribute to the mother, because the body begins to produce cortisol, which then can start thinning out the lining of the uterus and causes the mother to go into preterm labor. So literacy now is one that we've added to this iceberg because we realize that health literacy is another prohibitive factor for families. And we'll talk a little bit more about that as we move forward. It's that one in the middle. Yes. I made all the mistakes, so she doesn't have to.
I planned that. So I was thinking about this, and this fits in nicely kind of where we're going to go next with the presentation, but infant mortality, if you think about how infant mortality is talked about on the news, let's say, a lot of times, or even just amongst people, oftentimes the message is, well, you know, if women just didn't smoke, or if women, you know, ate better. But it's so much more than that. So a lot of the work that we're doing, like Denise mentioned, is steering away from, it's not just about individual choices, but it's also about what choices are available, resources, and all the other root causes that we're going to talk about. So I just wanted to keep that. Oh, yes. Oh, I got it. Oh my. We're not. I got it. This is like, we're not used to this high-tech stuff. We were really excited to have our own AV person because that's usually me, and I don't really know what I'm doing, clearly. So we're actually going to start talking about what some of these terms mean. We toss around, and I say we as like kind of a society, I feel like we toss around health disparity and health inequity quite a bit, but they mean two different things. So we just want to take a moment to have you maybe talk to the person next to you or just by yourself, jot down maybe some ideas of what you think those words mean, and then we'll talk about it as a group and go over what some of the definitions are and what those things, how we can apply those things to what we're doing. So if you can just take a moment to think about it and write down some thoughts about what you think those terms mean, that'd be great. I'm almost more comfortable with the...
I know, because we know what it'll do.
That's two to move. Oh, yeah. Go towards you. It just seems so opposite. Like I feel like we're going forward, not backwards, but okay, towards us. Oh, towards us. I know that's not much time, but if you could wrap up kind of what you're talking about, that'd be great. Yeah. It's a quick thing. I hate to break up dialogue. Okay, so let's share some things. Does somebody want to share what they said health disparity means? Or even if you want to perhaps explain what you think might be the difference between the first two.
We said that health disparities was the gap in what it is. So it's the gap in resources, experiences, statistics. It's the gap in what it is. And health inequity is the gap in how or why it is.
Excellent. That's wonderful. I couldn't have said it better myself. So, oh, good. Great teamwork. So what she was saying, and what I would say as well, is that health disparity is specifically looking at the gaps in health outcomes, let's say. So it's looking at the statistics, it's looking at the data, it's looking at the disparity, the difference. Whereas health inequity is looking at what caused those differences and what are the underlying issues. And that's a lot what we're going to be trying to dialogue and talk about here. So very nicely done. I'll talk about social justice in just a second. Here are some examples of some health disparities. This is so easy to put together. I have a feeling a lot of you are aware of different disparities that might represent your sector. If you work in housing or if you work in employment or education or whatever it may be, unfortunately disparities, specifically racial and socioeconomic disparities, are present in a lot of different sectors and avenues. So I just threw up a few different ones that kind of show a difference of health outcomes and also different types of disparity. So the first one is one that Denise and I work on a lot with our programs. It's talking about in Kent County how the African American infant mortality rate is nearly 3 times more than the white rate. And that's a number that we hear a lot in our work. I do believe that our programs are showing and the community is showing that that racial disparity is getting smaller, so we're really encouraged by that, but it still exists. I believe not too long ago it was 3.5 times, so it is now 3. So that's encouraging, but that's a huge gap. That's a huge disparity. And if you're not familiar with infant mortality, it's kind of what they say is like an easy way to just kind of look at a community's infant mortality rate to kind of determine the overall health of the community. It's a really big indicator, and it's really important. So the next one is talking about healthcare coverage in Michigan, that African American and Hispanics are nearly twice as likely as whites to have no health insurance. The next one is talking based on income level. So like Denise mentioned in the beginning, one of the biggest indicators of your health is not going to necessarily be your individual factors, but a lot of times it's where you live, how much money you make, what is your racial background, all these different things. So that one is just talking about that individuals with a household income of less than $20,000 are nearly twice as more likely to be obese and 3 times more likely to smoke. So again, it's kind of talking, that's the health disparity, and the health inequity is looking at why that is. What are the social conditions that are in place? And the last one, in Michigan, death rates. You have a question?
Karen, I had a question on that first one.
Uh-huh.
That's Kent County. How does Kent County compare with the rest of the country? Is it typical for that rate to be 3 times as high in other parts of the country?
That's a great question. So just looking at, is this just unique for Kent County to have an infant mortality rate that's 3 times higher among the African American population? And I would say yes. I mean, it varies a little bit from community to community. I feel like we're almost somewhere in the middle. There are some communities that the disparity is a lot higher, and there are some that it's smaller. So it varies. I feel like, and you know, this isn't a 100% accurate thing, but I feel like we're pretty much in the middle. It's a good question. Yeah.
Using that kind of number system where it's 3 times more, like what is an approximate number? Like how many African American infants are dying because of
Like,
the situation?
what's the actual
in
number?
Kent
I have this wonderful chart that says exactly the rate, the number, that I can't, I'd have to get back to you on that to show you the exact numbers unless Denise can.
I don't. We're at 11.
I feel like presenting
11.1.
it that way, I mean, you could present it that way, but if you would go one more sentence and say what those numbers are, it would have potentially a stronger impact.
True. Because like what is that number? That is the difference between that 1 to 3 rate. Yeah, that information's out there and we have that, but I don't have it completely memorized. And the last one's talking about death rates from heart disease and cancer are higher among African Americans than whites. We loved adding literacy into our equity presentation, into our health disparity presentation. And one thing that we found from a report that the Community Literacy Initiative here did was that Bing Goy had acknowledged that improved literacy is the key to our county's success. It's such an underlying factor. It's so important. But I love how he said that illiteracy is not only a problem of the 22% of adult population that struggles with reading and writing, but it's also a problem of the 78% of the population who may be unaware of the issue. So it's not just the people that are struggling with it, it's a community issue, and I think that everybody, should be concerned about that. This is my angry baby slide, Because when we talk about health disparities, I work at the health department, we talk about health disparities quite a bit. And I was starting to feel like perhaps our society is getting desensitized to it. Like, oh yes, we know there's a racial disparity. Oh yes, we know there's this disparity. I feel like that's something we shouldn't get desensitized to, but we should get angry about, because we believe that when there's anger and agitation, it can move us forward to look for solutions and do something about it, as opposed to accepting it. The picture on the left is my, at the time he was probably 5-year-old son. He was done. He just was completely done. And that's kind of just accepting it, like, I can't take it anymore. This is hard work. I'm just done. And Denise and I kind of use that phrase a lot too. So just done. But the angry baby is kind of how I feel on the inside. Like, we need to keep talking about this. We can't give up. We have to keep working at it. We have to keep trying to figure out how to move forward.
Karen?
Yeah.
I just attended CRI. They just came up with data, and it's, blind, but from 2008 to 2010, in Grand Rapids, 16.7 deaths infant mortality for blacks, but it was 5.1 for whites. So I think that's the number you were looking for.
Yes. Yep, per 1,000.
Whereas in Kent
Yep.
County, it was 13.8, and it was 5.0 for whites. So there's a huge disparity. That was from 2008 to 2010, based on the Justin's data. So just thought I'd bring that up.
Thank you, Jorge. Thank you so much. So helpful. Yeah, CRI recently had a presentation about a brown bag lunch on racial equity and data. So thank you very much for that. So these are some definitions that we borrowed from the Ingham County Health Department. We have a lot of great leaders in the Ingham County Health Department that are helping us with this social justice health equity work. They had a work group that came together to collectively agree on some definitions around these words. Also, after the presentation, we do have some handouts up here if you're interested. And one of them is a handout of a lot of definitions regarding health equity from the Centers for Disease Control and Prevention. So that is one thing we'll have available to you if you're interested. But their definition of social justice, we really liked, so we wanted to use that, is a world which affords individuals and groups fair treatment and an equitable share of the benefits of society. And their definition of that was social justice. Their definition of health equity is a fair and just distribution of the social resources and social opportunities needed to achieve well-being. Another thing we really wanted to talk about is how it's very exciting, the momentum that is behind the dialogue work that Denise is going to briefly talk about that we're doing. I feel like there is a lot of interest. There's a lot of passion, there's a lot of concern, and a ton of compassion. And I feel like it's really helping public health specifically as well. So Denise and I both work in public health in one way or another. And I've been at the health department for 14 years. And the first 7 years I was there, I was a substance abuse and dating violence prevention educator. I went in and out of middle and high schools all the time doing presentations. I loved it, it was great. That is really important work. But I did feel that we were missing something. You know, when I was going from one school district to another, from one community to another, I had an equity lens, and all I could see were the disparities in living conditions or opportunities or social conditions or whatever it may be. And around 2007, I started working with the infant mortality reduction program that I'm a part of, and we started diving into those root causes deeper and looking at the racial disparities, looking at oppression and other things. And then as we were formulating some of this work and we looked back at public health specifically, this is public health's work. You know, and I'm going to show another slide later, we have a lot of functions specifically at the health department and within public health that we do that are very key to health, a community's health. But this is also part of public health as well, because the average life expectancy improved by 30 years, which is huge, during the 20th century due to a lot of public health and social change issues, such as improved wage and work conditions, universal schooling, improved sanitation and housing, and the civil rights law. As a public health educator, I was really excited to read more and learn more about how civil rights and universal schooling and all these things are part of our work. It's part of not just my personal life, but also my profession, that those things are keys to improving life expectancy and the conditions that we live in.
And so let's just take a deep breath here. Just inhale And then exhale. Because when we start talking about race and racism or class and class oppression, it's so very easy to get defensive. So we want to make sure that what we do is we have dialogues about these issues and these concerns, because we're not making accusations about people or about where we live or anything like that, our gender. We're not making accusations. We're just lifting up information so that we can have conversations about what's happening in our communities and maybe look to explore some of the root causes. You already advanced it. Thank you. So the health equity and social justice dialogues that Karen and I facilitate at the health department are just that. We dialogue because we believe that the wealth of information is in the room. There are some facts and statistics and other things and guided conversations that we have, but we want to make sure that we have an opportunity to share our ideas because we each have different lenses and different vantage points from which we look at these issues of injustice and equity. So part of the thing about our equity and dialogue sessions that are 2 days and they're free, what we do is we want to have interactive experiential learning through having dialogues, group activities, and challenging scenarios. We have some a little bit later that if we have time, we might be able to work together on something as well. But in the first session, what we do is we give a framework of the determinants and social structures or the root causes of health inequity. So we kind of lay out a number of different things, sort of like we did here today. We look at some definitions, so we have common terminology that we will use throughout our 2 days together. Bless you. And then in the second session, we do some addressing and applying. So that's the day where we have more time, where we'll look at case studies, we'll have different times to sit around and really start thinking about where we first heard about things in our community. Yes?
Where are you doing these? Who's your general audience that you're presenting to?
The question was, where are we doing them? They're physically located at the Kent County Health Department at 700 Fuller. But we invite people who have anything to do with social services, who have anything to do with serving our community to participate. The problem is not that we don't have enough people. We have so many people signing up. Like, we are filled all the way through the end of the year right now. But we will have some next year. And we can kind of, if we get an email list, we can send that out to you as well. Does that help you? Okay, you still have that pensive look, so I was like, hopefully I answered your question. Any other questions about the 2 days? Anybody in the room ever been to any of the 2 days? Oh, you're missing out. You are missing out. During our time together, we are careful, and even today, we're careful that we're not looking for a debate or we're not looking to debate. So we're not looking for a weakness in someone else's argument, but we are more looking for dialogue. So we look for shared meaning and a common understanding. We're not looking for success or winning. We're giving up our right to be right, and we are simply having an opportunity to broaden our own perspective. Because even when we did that exercise earlier, when we looked at the picture, it's interesting because sometimes what happens is things that other people say we never even thought about, and we're all looking at the same picture, right? So it is when we look at disparities and injustice. We all see it a little bit differently. So we're also not looking to defend our opinion, but we're looking to find places of agreement. We're not looking to search for flaws in logic, but we want to discover collective meaning. So the economic, we talk about the social determinants of health a lot because we realize that it's not just about the thing that's presenting. So if it's an issue of health disparities, it's not just about that thing, but there are other factors that play into it. So the social determinants of health are the economic and social conditions that influence the health of individuals, communities, and jurisdictions as a whole. So they include a number of these things, but they're not limited to them. So if people don't have, we could just say it's housing, but it's not just housing, it's safe, affordable housing. If I have to be concerned about the hole in my wall underneath my sink that I might have rats or mice running through that can affect my family, then that's a different thing than living in a safe house where I don't have to think about infestations in the same manner. Or if we talk about a living wage, That's a big issue. If we have people that are making so little money that they cannot survive, or they're spending most of their income to pay their rent in substandard housing, that creates and presents a whole nother host of problems. Or if we think about education and we don't think about quality education, we're missing out. Access to transportation. One of the things that we talk to people about is, I live in a community where I have bike trails in my community. So if I want to go out and ride my bike, I'm not using it as a mode of transportation per se, but it's recreation for me. And I have nicely paved bike trails. But in the urban cores of Grand Rapids, where some people are using their bikes as a mode of transportation to get to and from work, have you seen many bike trails? I haven't. I mean, anybody see bike trails in the urban core, like in the heart of the city? No. So we have to start thinking about things of that nature, thinking a little bit deep than just the surface issues. Also, the availability of food. How many people have heard the terminology food desert? We live in a food desert, where if you are in the urban core of Grand Rapids, the nearest grocery store is probably miles away. So if you don't have a vehicle, then you're depending on the rapid. And I don't know about you, has anybody ever tried to read that map? I consider myself to be fairly intelligent, but I had somebody ask me to help them, and I could not figure out what that was all about. And I'm from New York City, so I'm from a big city with a crazy mass transit system, but we had it on every corner. So we had either the option of taking a bus or taking a train, or we could hail a cab, not something you can do here in Grand Rapids. So access to transportation is another huge issue for families. So if I have a doctor's appointment downtown, let's say, our system used to be really, really bad here in Grand Rapids, but if I had an appointment downtown and I lived, let's say, on 60th Street in Kentwood, on Kalamazoo, you'd have to walk 10 blocks just to catch the bus, because there's not a bus that goes all the way out to 60th. So you'd walk to you'd walk to actually that big shopping center, so it's about 44th Street, to be able to pick up a bus that would take you all the way downtown to the hub, and then you would have to come back out from there. So a ride that might take those of us who have a vehicle maybe 10, 15 minutes takes people almost an hour, and that's if you catch all of your connections. So sometimes we don't think about that. When you go to a doctor's office, I know we work a lot with doctor's offices in Strong Beginnings, and some of the major complaints of our clients is if they got there and they were 10 to 15 minutes late for their appointment, they were told, we're sorry, you're gonna have to reschedule. And if you're a mom that's trekking 2 kids and a diaper bag with changes of clothes and anything else that you might need for a day-long trip to the doctor's office, the last thing you wanna hear is, I'm sorry that you're gonna have to reschedule. And it's unfair. And so one of the things that we try to do through these dialogue sessions is help people to understand maybe we need to ask another question. You know, is there something that's preventing you from getting here on time? Is the issue transportation? Because if it's transportation and they have, even if they have some form of Medicaid, some of our programs provide transportation, but people don't know about it. Now, it's not the best and the most reliable transportation, but it's another way of getting to the appointment. So we want to make sure that we are addressing not just the issue of the person not getting there on time and then penalizing them, but that we then look at working to provide better access to transportation, okay? Is that making sense? Okay, and then the same is with access to food and social connection and safety. Because if you are constantly worrying about where your next meal is going to come from, or whether or not your children are safe when you put them to bed at night, or whether or not you're going to make it, if your refrigerator is going to work, and you're not going to lose the food that you have stored in your refrigerator because you're having problems with electricity in your community. Those are all things that make it very difficult to rest well at night and get up the next morning, especially if you're functioning from a living wage. You have a child that's sick, right? And so that morning you wake up, your child is sick, you have to make a decision about what you're going to do, because most people who are lower wage earners, they don't get a lot of vacation and sick time for when their kids are off, right? You are aware of that, right? Okay, so I'm preaching to the choir. All right. And now we're learning that literacy, it used to not be a part of our slides, but we're realizing that literacy is very important, because if I don't understand what's being presented to me, then I'm not as likely to take advantage of every possible option. And we'll talk a little bit more about that later. So health literacy, and I'm going to read this definition because this came from Healthy People 2020, and it's the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. The degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. And I don't know about you, but if I've ever had to take medication, and you get the stuff from the pharmacist, right? It has that nice little summary sheet, and then you flip it open, and there's like 2 pages of cautions. But then you open the medication, there's like a 50-page, like, fold-out thing that falls down to the ground because it's so extensive about the side effects and the causes and all these other things. And again, we're fairly intelligent, but how many of you really understand what's inside? Right, we have people in the back going, yeah. I often don't understand all that stuff that's in there, but I also feel empowered enough to walk back up to my pharmacist and say, hey, can you tell me what the risks and side effects are and explain that to me? And they sometimes are frustrated, but I'm paying for that service. So I feel a little bit more entitled to have a response. So we want to make sure that not only is the information in the box and on the label, but that it's information that once they have the paper, you know, we could check that box and say, well, they have the information. But once the information is obtained, we want to make sure that they're able to process and understand the basic health information and services. Then we talk about health literacy requiring a complex group of reading, listening, analytical, and decision-making skills, and the ability to apply these skills to health situations. In certain cultures, physicians, my son had a brain tumor when he was 7, and I remember just the overwhelming feeling of being out of control, right? We as parents are supposed to protect our children and keep them safe from all these things that might come after them. But I couldn't do anything about this brain tumor. And so when I began talking to physicians, I interviewed the physicians. But culturally, for African Americans and for other cultures, somewhat, but I can speak very keenly to mine, you don't question physicians because they know what they're talking about. And so when I would sit down, and I was much younger than I am now because I showed you my grandkids earlier, and my son is 30 now, but I would sit down with these physicians and I would say, so tell me, how many children have you worked with who have brain tumors in the hippocampus region of their brain that are somewhere between 7 and 9? And they would look at me and they were like, why are you asking me all these questions? Well, because this is my child. And because you're going to start telling me that I need to give him medication that's very strong, and I need to make sure that you're considering everything that pertains to my particular child. And I had some physicians tell me some really crazy things. I had one physician, and I was in New York at the time, who simply said to me, well, who do you think you are? And I said, I'm sorry? He said, who do you think you are asking me all these questions? I've been to school for 10 years, and that's just with regard to the brain. And I said, and I've been caring for this child for 7 years, and you don't come home with me. So in the middle of the night, if he has some kind of reaction to this medication, I need to know how to respond. And I need to know that you're not flippantly just giving him the latest thing that's out there. And so the physician was very angry with me, and I basically reported him because he said, you know, people like these, you know, you people, you really just need to learn to follow instructions. And I was like, now, which people are you talking about? Are you talking about people in this community in Manhattan? Are you talking about, you know, what exactly are you saying? And he actually said to me, honest to God, and I was sitting there with my attorney sister, which was a big mistake for them, but he said, you know, people, you know, your kids that grow up in the inner city community. And I said, actually, we live in Stamford, Connecticut, and I commuted in for this appointment. So I'm sorry, but that was not the right answer. And he said, well, all we're going to do is we're going to cut his skull open, and he starts explaining this with my 7-year-old sitting there. And so I had a long conversation with his supervisor, because I was so angry that I was shaking, because I'm like, where's the sensitivity to this child hearing you're going to just cut his head open and you're going to use this to crack the skull and then you're going to do no concern for it. And then grouping me and stereotyping me with a group of people that you don't even understand necessarily, and you don't understand the root causes of the conditions that are happening in that community. So I was very upset about that. But now I had my attorney sister there who was helping me. And she identified herself as an attorney, and it scared the physician half to death. But not everybody has an attorney sister or someone who could go with them, because I was clear that I was dealing with conditions that as a mother I was too emotional about to be able to process everything that the physician was saying to me. Does that make sense? So when you're under all this stress, I knew I needed somebody to listen so that they could objectively process what he was saying, because all I heard was what Snoopy and the Peanuts gang heard when the adults were in the room. So all I heard was womp womp, womp womp, womp womp, womp womp. And so obviously I decided not to go with that position. And we went on from there. But that requires a level of skills that not everybody has, and that when you're under stressful situations, even if you have them, you might not be able to employ them as easily as possible. Does that make sense? And so needless to say, my son is fine. He's 30, he's married, we have 2 grandchildren, so we're happy about that. But then some more about health literacy. Persons with limited health literacy, and this is sort of what I was alluding to earlier, with limited health literacy skills are more likely to skip important preventative measures. One of the things after my son went through this condition and they removed the brain tumor, there was a 50-50 chance he'd be a vegetable. The margin of error was 2 millimeters. 2 millimeters. But because we interviewed several neurosurgeons and pediatric neurosurgeons, we got him to the best. I got several opinions. He had a successful surgery and was out of the hospital in 3 days, which was unbelievable. I'm grateful to God for all of that. But they told me after that, every 3 months I had to take him for an MRI because they wanted to make sure that nothing was growing back. And so if I hadn't done all this research and if I didn't ask all these questions, after like the first year, I would have been really tired of this process of going back and forth and they're telling me nothing's there, right? So what would I have done after a year? Stop going. But because I had this attorney sister and his dad and I were very concerned about his care, and we understood that there was a need to keep going, because when I felt like I didn't want to keep going, they kept saying to me, well, these things can grow back. And we don't know kind of what happens, so you have to be very cautious and you need to bring him back. And then it went from every 3 months to every 6 months to every year. But he did this until he was 14. So if I didn't understand some of these things, if I wasn't blessed with the challenges to gain some more health literacy skills, I probably would have stopped going somewhere in between there. So I would have skipped some of those preventative measures. And people today often skip things like mammograms, pap smears, and flu shots because we don't understand what the importance of them are. The other thing is that low literacy has negative psychological effects. Those with limited health literacy skills reported a sense of shame about their skill level as a result, and they might hide reading or vocabulary difficulties to maintain their dignity. And I think the higher the levels of education that we have, the more we understand if we have a question, we need to ask it. We shouldn't walk around and act like we know everything because that's not my discipline. So mine is accounting. So if you ask me something about numbers, I could probably help you. But if you ask me to interpret that long sheet that's inside of the medication, I can't do it. All those diagrams, I can't do it. So we have to remember that people might hide their reading or vocabulary difficulties to maintain a sense of dignity when they work with us as service providers or whatever our capacities are in the room today. And then patients with limited health literacy skills enter the healthcare system when they're sicker. So I don't want to necessarily engage, or if every time I go to the clinic I get a different provider who may be in medical school and may not even be accompanied by a physician, and they're not really answering my questions or explaining stuff to me, when I get sick, guess what? I'm going to wait, and then where will I go? To the emergency room, right. And so they wait until conditions are worsened, but then they wind up in an emergency room, which is a whole nother set of complicated circumstances. So persons with limited health literacy skills makes greater use of use of services designed to treat complications of disease and less use of services designed to prevent complications. Consequently, there's a higher rate of hospitalization and emergency services use among patients with limited health literacy. The higher use is associated with something that makes us all very angry: higher health care costs. So. When I come back to you, we'll start here. Okay.
This is kind of something I was talking about earlier, but when I was sitting here thinking about it, it's a primary prevention social justice framework for public health, but you could really apply whatever it is, whatever area you work in or are passionate about at the top as well. Basically, it's just looking at adding social justice to our work. So for public health, we're looking at our conventional interpretation is doing things that we've currently been doing for years that helped with increasing our life expectancy by 30 years. And that's things like food and water safety, immunization, smoking cessation, those fabulous things. And in our workshop, we also talk about both and. So we aren't talking about not doing that anymore and instead doing this, but we're talking about continuing to do that level of work, but then adding in our social justice interpretation, and we can do that in all of our fields. So attending to the social determinants of health and addressing and confronting root causes explicitly. This is going to be homework for everybody. We don't have a chance to watch this, and it was actually only like a 2.5-minute video, so it was a kind of like a trailer, a teaser. But if you could write down unnatural causes, if you haven't heard of it, we think it's a great documentary that is about our inequalities making us sick. There are several different episodes that pertain to different factors of health, but it's very, very interesting, and they have a fantastic website. So if you just go onto their website, you can see a lot of the different video clips. We have a few copies that you could borrow if you'd like to watch it, and there are also a ton of great interactivities on the website as well. So that's our session homework we wanted you to check out. And basically this slide talks about an overview about what unnatural causes is all about. So these are the 10 things to know about health, and those are on we have that as a handout over here as well that lists these things and then also talks about each one of them a little bit more information. But just some of them to kind of pull out is that health is a lot more than health care. Health is definitely tied to the distribution of resources. Racism imposes an added health burden on top of everything else. I love this one, and I kind of paraphrased it earlier, but the choices we make are shaped by the choices we have. Just kind of going down to the end a little bit, that health inequities are not natural, and that we all pay the price for poor health. So again, if you'd like to know more about that, check out Unnatural Causes, or we also have a handout with more information over here. And this is the health equity approach, also from the National Association of County and City Health Officials, which is kind of, in a way, their take on unnatural causes. It's very similar, but I really like looking at social responsibility versus just lifestyle, and also looking at the causes of risky conditions versus just risky behavior. So it's, again, just kind of different ways to look at things. And I also feel like some of this language, some of these bullet points, are really good ways to kind of put that into some dialogue and see where it goes. Like, kind of add those points when you're talking about something and see where the dialogue takes you. Okay, now I'm going to do something really fast because we're running out of time. I'm going to go way ahead. But you know what? I'm going to quickly say that one thing we also talk about in our workshops that I think you can just quickly hear about for a minute and apply this to your own work is that one thing we try to do, I'm going to use this one actually. One thing we try to do is change the question. So a lot of times we talk about just adding an extra lens, looking at things through a different lens and kind of analyzing it differently. And instead of only asking, why do people smoke, trying to dig deeper and look at what social conditions and economic policies predispose people to the stress that encourages smoking. So it's just kind of adding that extra layer. And it's not something that we have like a toolkit or like steps on this is how you do this, but just kind of thinking in your head, how can I change the question to address the root causes? or to get to some of the underlying issues that may be present. Don't worry, not missing too much. We want to close with this slide here, and this is with equity, inputs may need to be different to achieve equal outcomes. So we're all different learners. You know, some people it's really helpful to have research and data, and some people it's also really helpful to have visuals, and we feel this is a really helpful visual when looking at these things. That equality is just giving every single person in this situation the same box. Well, that doesn't really help out this guy that's shorter here on the end, does it? So in fact, it makes the person that's really tall be able to see even more, as opposed to kind of leveling the playing field. But if you look at the slide about equity, it's more about looking at what each person individually may need to be able to achieve the same outcome. So if you want to Google this, I had seen it in a presentation. I believe I Googled basically equality versus equity, and you can find it. I've seen a few different versions that all basically mean the same thing, that show the same type of thing. The last thing we're going to close with is our determinants of equity. And we have this as a handout over here. We borrowed this with permission through King County Health Department in the Seattle area. And this is just a great way to, again, maybe have this with you at a staff meeting or a coalition or wherever you might be. If you're kind of stuck on a conversation or looking at solutions for an issue, this is helpful for us to kind of pull this out and look at those different things that are going on under the tree. So it's also flipping it from the determinants of like the negative type things to actually this is what we need and want. And literacy is a piece of all these things. It's quality education. It's family wage. It's early childhood development. It is weaved into each one of these things. And we actually hadn't realized that until we were preparing for some of our literacy work here as we were looking at equity and tying those things together. As we looked at our work, we realized that literacy is tied into all these different components that we've been talking about for quite some time. So that leaves us with about 1 minute until you have to go. I don't know, Denise and I will be around, and there are some handouts up here, but if you have any questions, just let us know, and we hope that you enjoyed the presentation.